our session now. So thank you so much, colleagues, and thank you for joining today's session. We hope to learn more from it, and we hope to share our experiences together. And we are introducing a new model today, or a new batch that will be running very well with it as of next year. So today will be just an introduction and a little bit of discussion, and there are more of concept that we'll be looking, which will help us when we continue with our session going forward. So sharing all what we think we can share together. So may I also test as promised from our last session for this batch. Apologies for that. We're still working on it, but then we couldn't delay the batch so that we can move as quickly as possible with our sessions. So, but it will be available. And also, let me also appreciate that for those who have been able to finish the post-test of the previous page on pain management, we have been able to share their certificates with them via their emails. We hope you have got your certificates of attendance. If not, yet you have finished the post-test, please WhatsApp me on my WhatsApp number so that we can be able to help you on that. So that's my WhatsApp number on chat. So you can then share with me your name so that I will be able to go and check you there. Otherwise, we've tried to do that. We are hoping others are still to join us. With me here, I have Mr. Pennington Dlamini, our senior nurse here at hospice, and I have Margaret Gameza with us, and we are hoping other team members will join us. May I give this opportunity to Simpiwe to greet us.
Simpiwe, me?
Yes, you can go ahead, Simpiwe.
Okay, thank you, Tim, and thank you. Training. My name is Simpiwe Dlamini. I'm with Georgetown. We're still following and in this experience, sharing and training, so that we are a bit capacitated by those who specialize more on palliative care, to look at all the dimensions of palliative care for our clients whom are suffering from pain, as a broad perspective of pain, which can be emotional as well, and rather than only focusing on this physical pain. So thank you for I would say the second session for this quarter now that we are taking, as we have finished last time. We are grateful and hopeful that we are going to contribute and participate, so that we enjoy the discussions of the cases, as well as we appreciate and acknowledge the strategies that are going to be rendered into us. Thank you, Tim.
Thank you so much, Ngosi. And Sigi, would you like to greet us with your team? Nancy Gelelo, would you like to greet?
Colleagues. Afternoon, colleagues. My name is Nontsigelelo Ntuli from RFM Hospital. Manzini, Eswatini. I'm happy to be. Thank you.
Yeah, today we have a little bit of network challenges, but I hope we are getting one another. May I give Mr. Pennington to greet you?
Good afternoon, team. My name is Pennington Dlamini. I'm a palliative care nurse here at Hospice at Home. Thank you very much, team, for being together in trying to extend our knowledge in palliative care. Thank you.
Thank you, Mr. P. May I give my comments also to greet you, team?
Good afternoon, colleagues. I'm Zota Gamete with the Eswatini Hospice at Home. Thank you for taking your time to join and to learn, to impact each other. Thank you.
Thank you. I hope, Malaika, would you like to greet us? Malaika, would you like to greet us? Okay. On the instance of others will greet us when they join us, colleagues. May I try to share our presentation? Please bear with me while I'm still trying to get the document. That we have here. Please let me know then you see my screen. Otherwise, I'm trying to share it here. Yes, I'm trying new technologies today. So I'm trying new technologies I've never used before. So bear with me. Okay, this one is not working. Let me try another way. Can you see my screen?
Not yet.
Okay. Let me try again. A moment. I'm operating a machine I'm not used to use. Yes. A little bit open. It's coming. No, it's coming, colleagues. But today, what we are going to do, we will be looking around on the principles that we'll be adhering to while we are discussing going forward on how to manage certain symptoms. So that we'll be doing today. So we will be looking around on how to manage symptoms, but we'll be only today looking at certain principles that I will be sharing with you. Then we will have a case presentation from them. Can you see it now?
Yes.
Okay. Okay. Let me try to put it on presentation mode. Yes. So today we'll just be looking at the principles of symptom management or symptom control in patients with serious illnesses. What we want to emphasize is that there are certain principles that we need to adhere to that might not be applicable maybe sometimes to people who doesn't have serious illnesses, but they can be applied across. So, but they are most important when we are dealing with people with life or serious illnesses. So we will have more discussion, more questions, and across the presentation. So I will request that if you have any question, please do ask whenever. Don't mind stopping me and raise your hand and say whatever you want to say. So, and then we also look, what we are going to discuss today, we are going to look at the guiding rules to do what matters most to the patient. And we also will look at, we will introduce the importance of having advanced care planning, especially when it comes to symptom management. And then we will also describe the 9 principles of symptom management in palliative care. Then we will have our case presentation from RFM Hospital. The thing that we need to ask ourselves every time we have a patient in front of us is to ask ourselves that what really matters most now? What really matters most? This is the patient in front of me, but then what really matters? And we need to listen to what matters most. And then we need to do what matters most. That one is very important whenever we are dealing with people with serious illnesses and we are attending their symptoms. We have been dealing with pain, which is one of the symptoms that we deal with, but now we'll be looking closer to other symptoms. So the question that we need to ask ourselves are, ask yourself, what matters now? Should I do this? Is this that matters now? 2, you need to ask yourself and listen to what matters. And most of this, you will get it from the patient and the patient families. And then you do what matters. There are many things you can do in the list, but you need to narrow them, everything down to what matters. And then there are 2 rules that govern decision-making in doing what matters. And these ones are the golden rule and the platinum rule. So the golden rule is the one that we are used to, which is on me, or is centered around me. So in short, it's clinician-centered. It's around you. Your decision you're going to make is based on you. So whatever I'm going to do is based on what I think or what I feel. So that's what we call the golden rule. Then this one, it's saying that treat people the way you want to be treated. And the problem with this one is that we have different priorities as people, which must be totally different from the patient. Let me make an example. You have a patient who will present with anorexia and cachexia in the facility and is now approaching the end and is not taking any meals. And then you will find that the patient doesn't want to be given any meals anymore. But because you can prefer to be fed by that time, you will continue to do that because the golden rule says, so that's what we are saying. That's the golden rule. But then in palliative care now, we are moving even closer now to say, in symptom management, we go to the level where we say now we look at the platinum rule, which is now, it's patient-centered now. So we are treating the people the way they want to be treated. Regardless of whatever symptom the patient might be experiencing, we need to treat them the way they want to be treated. Then it means this one is patient-centered. What the patient prefers at this point and what matters most to the patient now. For example, you may think maybe taking the patient to hospital to manage a certain symptom will work, but that not matter to the patient, and you are not going to do that because that does not matter. I don't know, maybe I can ask the question, which one do you easily feel tempted to do, and maybe why? Between these two rules, which one do you think you are easily tempted to follow, and why, if ever you have that? I can appreciate, yes, Simpio, which one is easier to follow?
Okay.
Yes, Simpio,
Yes, thank you, Tim. It's easier for us as nurses to follow the golden rule because we are tempted to generally think or feel that clients have less information. So we feel like somehow they are deciding or making decisions through or with their insufficient information and knowledge, yet forgetting that it's what they experience that makes them to ask for those interventions in relation to what they feel impact them most, instead of us thinking that way. Thank you.
Thank you, Mr. Dlamini. It's Mr. Dlamini. We are easily tempted to look at what we feel or what we think, and then we apply the golden rule. If it was me, being an old woman or being an adult with a penile cancer surgery, I will not appreciate to be asked about my sexuality. And then you end up not asking the patient because you have applied the golden rule. But if you go for the platinum, you will discover that your symptom control then will be driven by, yes, this is the problem, but what matters now for the patient? You will find patient run through 977, we are calling 977, someone is in trouble, yet the patient has been anguishing in pain for some time. But now what matters most for the patient is to be in his house and spend the last days there. So it's very important to apply the platinum rule. So when we are doing these rules, it is very important to highlight today, as we are going to plan and continue with the symptom management, to understand the issue of planning ahead. In palliative care, there's no surprise. The only surprise is a miracle that the unexpected improvement has happened. The intervention of God has taken place. That's the surprise we can have. But deterioration through the disease trajectory is not a surprise. There are things we expect when the patient is going down with the trajectory. One of them is cachexia and anorexia. We expect them to have anxiety and depression. We expect them when they are bedridden to develop pressure sores. We expect a lot when they are going down. We expect them to have dry mouth. We expect them to have pain. So there are things that are not a surprise in palliative care. That's why even palliative care images in palliative care, they are well defined. So planning ahead then helps, because we have found that we spend a lot of money trying to sort issues that we have planned for and we have managed for. So the aim of the advanced care planning is to establish what matters most for you. The simplest question is, if you could not be able to take food, what will be the most important for you? A patient then will tell you what will be important for him or her. And this one helps us to give the patient a time to plan. Most of the time in our facility, we assume a lot and we don't give the families and the patient to plan ahead. We just focus on what is here and we think life ends here. Yet we know as clinicians, the journey will continue and the tradition is still to go down. But then we don't inform them, and then that one leads to a big challenge whereby then we have surprises. And most of the time, even in my understanding and in my experience in the practice, that even in Maswati, they appreciate to discuss their future. The issue is, how do you approach them to do that? So we discussed it in our previous sessions on how to go about communication and even in discussion on ongoing goals of care. So those are the skills that you need to unpack this. Even in the symptoms management, we need that, so that we know they are able to discuss and looking ahead. Whether they have organ failures, then you will find that patients will say, I want paracetamol. And when we're looking, the patient is requesting to take paracetamol, but the patient has chronic liver that is high. So we need to plan ahead so they can be able to discuss, even if they want to refuse treatment, when we've given them the time to plan. So there are no surprises when it comes to this. We expect the symptoms. And when we are doing the ahead planning, we are saying that you need to give reassurance of compassionate care that is individualized to the patient. You know, some patients, they are scared to share what they want to be done on them. Let me make an example. Patient who is scared to tell you that he doesn't want to take the medication you are giving them because of whatever they are doing. And then the patient will feel like maybe because he's scared, you will not give them the medication. And also, advanced care planning also gives patients self-control, especially in their last days of life. So they are able to make good decisions concerning their lives. And it enables the patient to focus on living as well as the end. How will I progress with this condition that might not be reversed, maybe, or reversed? And then also, we also have what we call time in palliative care. You need to know when to start this. And you need to be very cautious when it's time, don't miss it and postpone. So the conversation can take place over several different occasions and updating of information, and as time passes on, maybe they are grieved or they've lost a loved one, and then there are things they want to discuss. They can come and discuss certain issues with you, then discuss certain symptoms with you and say, I don't want this and this. Maybe a mother or a relative has died and maybe was on NG tube, and then the patient will come and say, I don't want NG tube when I'm approaching the end or when I'm not able to eat. So we are able to get those things. So my golden rules, they are there, and they help us to know what to do and how can we to make decisions when it comes to the symptoms that we are going to discuss as we go further down. So we need to understand then now how those rules work. And patient goals, they are different. So when you are using these rules, it helps you to achieve and know what exactly this patient wants to achieve in every symptom you want to manage. If it's pain, what's the score? What do they really want to achieve with this symptom? If it's this, some patient will say, I just want it to stop a little bit or at least less frequently. For example, there are symptoms that may not be stopped completely. They will be there. For example, the pain is one of those symptoms that you may not eradicate it completely. So we need to know those goals. Some patient goals may be, I wish to maintain and improve my functional level. You know, if I can be able to play with my kids, then they will be fine, regardless if it's the symptom is still there or not. But if I will be able to do this, if the patient is able to work, they will have certain symptoms that will stop them from working. If I will be able to fellowship with my loved ones, maybe they have wounds, and then their goals will be with the wound. I know this is a wound that may not be healed, but then if I can be able to have time to socialize with my family and loved and friends, then if I can be able to have time with the church. So the goals of the patient are the ones that will drive you on what to do concerning the symptoms. So one of the rules that we have is to assess and diagnose the cause of symptoms before planning symptom management. This we have been saying it many times here in palliative care. This is what we call comprehensive assessment. So you need to find the root cause. You see, I've put a picture there. When you see the big fig tree outside, there is a deep problem in that might be a cause of many. You will see it when we are going down with the symptoms, especially when we reach nausea and vomiting. You will discover that nausea and vomiting on top, we are just seeing people spouting or being irritated, but the causes might be many. So treating a symptom, you are not going to solve the problem. So it's very important to do comprehensive assessment and diagnose the cause of the problem. What is causing this problem? So that you don't address the symptom, but you address the cause of the symptom. So that one is very important. That's why when we talk about comprehensive, we have social, psychological, spiritual, cultural, and physical. So you need to get to know. Some patients will have anxiety of death, and you will find them nauseatic and behaving otherwise. And then when you will come and give them antiemetics, and the problem will persist because of the anxiety until you solve the anxiety. Some patients, you will find them depressed and stuff, and then you will find that the depression is caused by another issue. Some patients, they will have many causes. The issue in palliative care is that to save resources, we are wasting because we are addressing the symptoms. Think of addressing anorexia. You will rush to multivitamin, you will rush to prednisolone, you will rush to all these things that we use to address anorexia, only to find that the patient has been given bad news. So it's just a psychological issue. You just need to sit down and discuss the matter, and the patient will feel free and anorexia will be gone. But until you do the deep analysis of the problem, let the patient say the patient has went for chemotherapy, and then now the patient is vomiting. And then when we are giving any drug, and then you don't know the real cause and where is the problem, you will spend a lot of resources, and then at the end, we will say there are no drugs, there are no what, because we have wasted the problems. So we have wasted the resources addressing the wrong cause. So let's find the real cause. What is it that is leading to this problem that I'm seeing? Then from there, you can go for planning symptom management as usual as you can, because now we have identified the problem. So the causes might be many and will require multidisciplinary team. Another golden rule that we need to understand while we will be dealing with symptoms in palliative care is one that always in palliative care, you treat potentially reversible causes where appropriate. If it's non-reversible, don't try to reverse it. It will not reverse. What will happen here, you will feel useless, you will be depressed, you will try again. They will say, we don't necessarily, he does know his work. Yet you were doing your work. It's just that you were just reversing something that cannot be reversed. Stage 4 cancer, and you are trying to reverse that cause, and then it's not going to reverse. So you need to reverse the reversible. You have a patient, ECOG 4, terminal phase, approaching end of life in the last days, and you are busy putting IVs, you are busy putting NG tube, you are thinking we are reversing anorexia there. You are just wasting resources. You are not going to reverse that because the patient is already approaching the end. So you need to know what to reverse and what not to reverse. That one will help you to know when to stop and what to do. And another thing that you need to understand is that, thank God we have a great technology now, especially in terms of medicine. We have all drugs on our table. We can use as much as we can. But we need to understand that we need to consider non-drug approaches as they can be as important as of the use of drugs. So always look for non-pharmacological means before. That's why we have a multidisciplinary team with us. We have social workers, psychologists, doctors, everyone there, so that you can look for non-pharmacological means to deal with the situation, to reverse that symptom if it's possible, or augment your drugs. So always consider non-drugs interventions too. They will help you. You can see those my cartoons there. There's a playtime, dogs, everything that is there. Those ones are used for pain management. So music and everything, as long as it works for the patient, it matters most for the patient. Another one is that the management plan is influenced by the prognosis and patient choice and depends on the therapeutic goal. What exactly do we want to achieve that the patient wants to achieve? So, but then the way you can manage a patient who's in ECOG 1 or stage 1 of the condition and a patient who's stage 4 is totally different. So we need to know what interventions favors the prognosis of the patient. For example, taking a patient who is on ECOG 4 and already in dying phase and then trying to resuscitate that patient who is going, it's not going to work. But it's better on stage 1 or the patient was still functional, was not okay, even if we resuscitate, it's going to work. So it depends. You cannot, we will find that we take patients to ICU. The patient is anguished for years, in pain, is struggling. Now the patient is approaching, the symptoms are so severe, it's approaching the end. Instead of palliating, we think of reversing, we take them to ICU, ventilation, and all those things. When they're unconscious, we try to raise them up. Can you imagine the trauma? But we are still saying we are trying to help our patient. Actually, we are causing harm because we cannot balance between prognosis. And then when we're talking about patient choices, in the beginning, I said, we need to engage our patients on advanced care planning. We know that before the patient can die, there'll be anorexia, there will be severe pain and all the symptoms that are so distressing to the clinicians, to the patient, and to the family. So what we need to do then is let the patient understand their journey so they can make informed decision. What the patient say matters most should that happen. And remember that patient will frequently change what they prefer so they can achieve their goals. So we need to do that. And whenever we are planning, let our interventions be influenced by that. And then another thing that we need to understand is that we need to engage on regular reviews and reassessment. Here at hospice, we have what we call televisit, and we have what we call physical visit, whereby we go to the field and we meet the clients. And then once we have done that, we then come back in the office, even if the resources are not there to go back in the 7 days, but we have what we call a televisit. This one is encouraged by African Palliative Care, International Hospice Association. Actually, all palliative care are encouraging that if ever you are providing a home patient like we do, we engage on home electronic or the technology, the IT system whereby we can do televisit and stuff. This one helps us so that we do immediate reviews for all symptoms. So you know, I've given diclofenac or I've given Maxalon for this patient. I cannot stay for 30 days without reviewing what is the problem. So we do that, review and reassess. That one is very critical ever. We are managing symptoms. Even if it's depression, imagine prescribing amitriptyline and you vanish for 30 days. What will happen with the patient if he commits suicide? So we need to do the reviews and assessment. And then we set therapeutic goals of use of opioids as analgesic, no for sedation. You see, you prescribe the drug for that use. You use them for the exact need they are for, so that then they help you to achieve what you're looking for. And then another again is that all drugs need a review date. All drugs, once you prescribe a drug, put a review date. In the clinics we used to, or I think it's still done even now, when you are prescribed STI treatment, they will say, come back after 14 days or 7 days for review. How will I know if my drugs I've prescribed for my interventions are working? It's when I will have review dates for that. I'm giving you these drugs, you will use them for 14 days. That means after 14 days, you will either visit or do a call, or the patient will be coming back to the facility for review. If I'm prescribing morphine, the liquid one, and then I'm giving the patient 30 days review, the patient will come in 30 days for refill, which is together with my review, so that I can be able to use the minimum dose to achieve maximum effect. That one will help you do that. Otherwise, you will have a lot of drugs prescribe. You'll find the patient having their own pharmacy shops at home because nobody's reviewing. Everybody's prescribing without reviewing. Is this drug working for the patient? We have seen patients who might even sustain stroke because they've been on SCTZ that is not reviewed lifetime. So we need to review. In symptom management, we deal with immediate review. Then we talk about team approach. That's why we are here together and we have case presentation so that we can have time to share as a team. The name team, it says that together each can achieve more. Each one of us can achieve more. From Georgetown, if we are working together, each one of us can achieve more. If social workers work together with doctors, nurses, psychologists, everyone, nutritionists, dietitians, and we talk of physiotherapists, every one of us can achieve more if we are working together as a team. Once you are in solitary, you are finished. The last one that I will share with you, one golden or last one, that is very important is, nobody knows everything. Even if you can be a star in it, but you don't know everything. So what does it mean is, once I've tried to manage a certain symptom, but I'm unable to relieve it or take it down or meeting the patient's goals, I need to refer or inquire for specialist advice. If it's an oncology issue, I need to inquire from oncologist. If it's a neurological issue, the neurologist. If it's a social issue, so social workers. So you have to inquire from the specialist. Then they will help you achieve that. So here I will not tell this much because of time, but you will have it. This presentation will be available. It's already there in our platform. You can sit down and look at what I've shared there, which can be an algorithm that shows how you maneuver and how the factors affect one another before you reach the level whereby you prescribe your drugs. But what is very important is, in your management, remember there are reverse. We reverse the reversible. If it's not reversible, then it means it's a matter of discussion and agreement, and goals of care is to shift with the patient. Then we have the drug therapists and non-drug therapists. Thank you so much, colleagues. That's what I have as an introduction to our presentation on symptom management principles. So this is what it's much a little bit different from other approaches of care. But in palliative care, when we are dealing with serious illnesses, where we know death is something that is coming and we can predict it within the journey of the patient, then these principles can help us to manage those patients. Remember, all the technologies we have learned from school and everywhere, we then harness them within this. Actually, this is the best practice of palliative care. Can I give Mr. Dlamini? I'm seeing he's raising him. Yes, otherwise, that's what we are introducing to you, colleagues, today. That we say, as we are going for Christmas, as we are preparing to continue with this session next year, can we understand the principles of symptom control in palliative care? Mr. Dlamini. Simpiwe, Mr. Dlamini.
No. Sorry, Tim. I didn't lower my hand. Sorry.
Okay. Anyone who can share something or ask or comment on these principles we have just shared? Otherwise, we know this. It's just that sometimes we are not sure what to do. And remember, there are ethical principles that guide us in palliative care. And then there are the communication skills that we need to embrace in palliative care, so that even the difficult news we need to discuss. You know, sometimes, you know, it's not being a failure if you are not able to control an unreversible symptom. If the symptom is not going to stop, let me make an example. You are known to be a wound specialist, and you have managed different wounds, but one day you met a non-healing wound, simple a cancer wound that cannot be healed. And when you're doing your diagnosis and assessment, you discover that this wound, the cause of this wound is the cancer that is behind. And for you to heal this wound completely, you need to eliminate the cancer that is behind. Then that one tells you this is a non-reversible symptom. So then what I'm going to do, I'm going to palliate this wound. So then we will address how do you go about in managing a non-healing wound and a pressure sore, how do we deal with that one? Because these are two different things. I'm having my patient who is having bleeding. I'm having a patient who has depression. There are many things that the patient they go through. I'm having patients who have cachexia. That's one of the some symptoms I've ever met in palliative care when patients have cachexia and anorexia. So those ones you find that they are not reversible at some point. That how do I deal with? I've given my patient all drugs that I know, but how do I manage it with my patient, especially when they are approaching the end? So we'll be also looking at these ones during our session. That's why I can say, don't miss even one session because the symptoms we are going to deal with, they are very important. We are dealing with nausea. That is much problematic. You are giving certain drugs that you know, but until you get the cause, you will be giving what we call this metoclopramide. And you will discover only what you needed was just prednisolone. And then you will be done, because giving metoclopramide in a brain tumor, you are just wasting your time. You see, giving metoclopramide when the patient has constipation, you are wasting your drugs. So sometimes we misuse the resources that we have because we are trying to reverse something without knowing what exactly is the cause. So we'll be looking at unpacking such issues and how best we can do it. So we are going to look at those symptoms. You can see it in our module. It is there. I don't know if I'm closing anyone behind before we can move to RFM case presentation, which we can learn from it within this 20 minutes that is left. I'm paying my data is not yet finished. Is there anyone who wants to add or comment? I was just laying the foundation today on the principles that we will be following. Okay. I don't see anyone raising a hand. So allow me, colleagues, to share presentation for RFM. Are you ready, Ntuli?
Yes, Mr. Mahlangu.
Okay, can I try to put it for you? I'm hoping it will show up. I don't know if you can see it now.
Not yet.
Okay. Yes. Now there it comes. Yes, I think you can see it now. Yes. You can go ahead.
Okay. Afternoon once again, colleagues. My name is Nonsikele Lontuli. I'll be giving a case presentation which was supposed to be presented by my colleague, Nurse Zinhle Zwane. Unfortunately, she's unwell. I'm presenting a case about a patient who is a follow-up, 50 years old, a male with penile cancer. The patient's problem is that the client has an ulcer on the right inguinal region. There is progressing. Client have 5 children, eldest being 9 and youngest being 2 years old. He is the breadwinner of the family and only runs a mobile money business. Concern. Client is worried on what will happen to his family if anything happens to him. Our concern as healthcare providers is that the stress that the client is going through might be a problem to his health. Chief complaints, patient complaint of lower abdominal pains, ulcer on the right inguinal area, and fatigue. Significant medical surgical history. As RFM Palliative Care, we received the client on the 6th of November 2023, was referred from RFM Surgical OPD for palliative care services and wound dressing. Patient is a known HIV patient on treatment since 2013. In March 2022, client started having a lump on the right inguinal area. Was seen at Babane Government Hospital where they did a biopsy and confirmed that he had penile cancer. In April 2022, he had a penile amputation. May 2022, he started chemotherapy. March 2023, he was sent to South Africa for radiation where he responded really well, came back home in May 2023. The client said he had a traditional illness in August 2023, which made him bedridden for some few weeks. He used some herbs and he was fine and able to walk again. He mentioned that the radiation helped him a lot because the ulcer on the right inguinal area healed. But in October 2023, the ulcer came back again. Went to hospital where they advised him to do alternative days dressing with Flagyl and Ectisol. Relevant past medication, patient was using paracetamol 1 gram orally 3 times a day. Current medication, the patient is using paracetamol 1 gram orally 3 times a day with diclofenac 50 milligrams orally 3 times a day, and he is on ART. He's using TLD once daily. Social history and pertinent family history. Work status, the patient is ambulating. Education, patient ended school on Form 2. Occupation is self-employed. Socio-economic class, middle class. Marital status, patient is married. Lifestyle habits, he has history of alcohol and smoking 14 years ago. Relevant health condition in the close family members, there is none. Advanced directives, they are not yet discussed. Review of systems, vital signs, temperature is 35.6 degrees Celsius, BP 116/77 millimeters of mercury. Pulse is 74 beats per minute. Respiration is 16 breaths per minute. Oxygen saturation is 98%. Pain score 6/10. ECOG functionality is 2. Other symptoms, pain, it's severe. Dyspnea, there is no dyspnea. Anxiety, it's moderate. Agitation, it's mild. Depression, mild. Drowsiness and fatigue, it's mild. Nausea and vomiting, there is no nausea and vomiting. Anorexia is mild. Constipation, no constipation. Dry mouth, no dry mouth. The patient has poor mobility because of the ulcer on the inguinal region. Focused investigation, patient did biopsy and it was found that he has penile cancer. Further plan, client is being seen from both RFM palliative care unit for pain management and wound care and Moneni oncology unit for the cancer management. On the next visit, we will will see RFM social worker so they can help him come with some ideas on his concern about who will look after his family if anything happens to him. Client to go for a follow-up at Moneni on the 14th. Also, client was asking for advice if he can consult from a traditional doctor for the wound. Thank you.
Thank you, Nduli, for the wonderful presentation. There are very interesting issues here. Nduli has presented about this 50-year-old male with penile cancer. So, and the problem is that the client is an ulcer that in the right inguinal that is progressing. So he has a progressive non-healing wound. Suspicious may be cancer, as the patient has a penile cancer that and he has done radiation, chemo and stuff, and is still undergoing oncology care at Manzini Hospital. This 50-year-old male has 5 young children, and the eldest one of them is 9, and he's 50 years old, but the eldest is 9 years, and then and the youngest being 2 years, and he's the breadwinner of the family, and he also ran a mobile money business. And then now the patient's concern, as Nduli has presented here, is that what will happen to his family if anything happens to him. Our concern as a healthcare provider is that the stress that the client is going through might be a problem to his progress. Thank you so much, Nduli. I don't know, may I hide it so that I can also see those who are raising hands? Yes, here's the case, colleagues, and also our team. Can we help them help this man? I've just presented their concern, and thank you so much, Nduli, for such a wonderful case. How can we help them, colleagues, so they can do better? I've heard that the patient is scheduled to come back, so they will be discussing this matter of advanced care planning and the future concerning the family, because he's 50 years already, but the oldest is 9 and the youngest is 2. And he has this unhealing progressive wound now, and with the history of penile cancer. And he is not employed anywhere, but he's a self-employed person who is working in a mobile money. I can think of this wound, that this wound might be smelling, and I'm thinking about him working at the mobile money station, and I'm wondering about the wife, what is happening. But can I leave it to you, colleagues? Can we advise RFM team while they are planning to manage this patient going forward? Any comment? I'm happy today I see Sister Trustin Bata is back after a long time. Yes, we can advise colleagues, team. I have a great team here. I've been joined by social worker. Miss is here today. I think she can contribute to what other social workers on this issue. And I'm also having Mr. Pius is back. Mr. Simpiwe, what can you say? You can unmute and share, Mr. Secretary.
Okay, thank you, Tim. Thank you, Nduli, for this presentation on the case. As it has been highlighted that now we are talking about a 50-year-old gentleman having children with the oldest being 9 and the youngest being 2, and the stress and worries of what will happen to his family. It's unfortunate that there is no information about the relationship with the wife, and we are not seeing the wife in any picture for close support as well. But I think as the client is stressed with the issues around family support, from his perspective, to say is supposed to be the one who's providing for the family. Somehow I'm seeing a picture where this client might not honor well clinic appointments because he is trying to provide for his family so that he can be out there and continuing with his business so that he can provide. So that's where I feel we need to loop in the services of social worker who can explain well that even though the family needs to be taken care of, also he needs to be taken care of in the way that can be a little bit more supportive, as well as we are monitoring the prognosis of his ailments at the moment. And I'm looking the perspective of a social worker that they can involve the family as well, so that the client, yes, our focal client is the 50-year-old, but we need to incorporate the family so that we now address our client as being part of the family, so that he can also allay anxiety. So for support and a reciprocal support even from the family to say, he is sick now, so we as a family, we need to also take care of him. We need to also reduce the stress, if possible, that we exert on him, so that he can also look after his health. As it seems like the priority for the client at this moment is being the provider or the head of the family. So we need to address these psychosocial issues around all his worries. Thank you.
Thank you so much, Mr. Dlamini. I don't know, I can't even add from what you've said. I think you have picked what Mr. Dlamini is sharing, that you need to, when we're discussing this, have in your plan to engage the family on whatever you are going to discuss with the patient concerning going forward, and the family, so they can be supportive too on whatever he will prefer and you will end up having. What I'm happy for is that the patient initiated the advanced care planning. So now we know what matters and how best we can support. Mr. Puma, are you raising your hand? Anyone else who can want to share? Any comment from Mr. Dlamini's suggestion and comment?
Okay, thank you very much, Mr. Dlamini. Okay, concerning involving the social worker, we are still trying, though the client is still hard on receiving our initiative, that we were thinking of having a family meeting so that we have the wife's view concerning this issue, because we once asked about the wife, and he said he was working at the factories in Matapa, but he then said he must stop working.
Okay.
That's all.
Thank you. Yeah. What a case. And, we can work together and make his journey and their journey good. I'm also thinking about the wife and these children. I was seeing my director counting fingers, looking at the highest 9 and 2 and 5, like, what is happening here? But I think another issue, I'm not sure how far he is, because maybe it's the financial issue to come to you, but if then you have some plan to meet him at home. Sometimes they feel comfortable when you go to their home where they feel they are the bosses. So if there is a possibility to do that, that can be great. And if ever you have initiated the issue and you feel that maybe it was hard to crack the nut, I can say that maybe you can collaborate with our social worker and see how you can organize a team visit with your social worker together, so that maybe you also do the transition. I know RFM, sometimes resources might not favor you, so that then you can initiate the discussion. But the most important thing is to request him, can we meet your wife to discuss this, give him and then if Anema fears, then you will sit down and then give the veil of why is it important to discuss. You will find that maybe you will end up saying, no, it's okay, meet the wife, and then you can then meet them together, because that one can be very important, especially now that we have created the rapport with him. And the man is at his age is not easy, especially now with the penal amputation. There's a lot of insecurities he's going through. Because if the wife is still able to go to Matapa, the master possibility is less than 50. Is in his 30s maybe, or his 20s, we don't know. So yeah, there's a lot of insecurities, especially please don't ignore the sexuality issue. At some point, once you are done with that one, please also check his sexuality issues, because I have one client that we have in hospice with the same amputation on the penile. One of the issues he cannot stop talking about was the fear of the wife leaving him. So I promised him that we will meet and discuss this, him and his wife, in our closet, so they can open up and then discuss and see all the alternatives to sexually express themselves. Mr. Dlamini.
Thank you, Mr. Mahlangu. Yeah, I'm worried about now the issue of wanting the wife to stop working. I'm also trying to figure out what could be the reason behind that, but you have already alluded to some. It's a too sensitive area which needs the man to feel that he is still on control of everything. To foster that into the mind of the client is to visit the client where he is comfortable and where he is the boss and where he calls shots, which is his home, where he can now start talking about the fears. It's somehow a little bit obvious to say it's the issue of sexuality, but also they can project it in a different way to say, no, when the wife is at work, no one is taking care of me, so I want her to stop so that he can take care of me. And he might put it in that way, yet you will address that to say we need to balance that with our economic status, to say if you are no longer able to provide as you were able, so let's have support from within the family, which is the wife now trying to work so that he can continue supporting the family as well as she is your supporter. Then you'll be addressing it like that. Yet that is not the issue. The issue is the sexuality part and the issue of insecurity, to say the wife is going out and is being seen by other men. Maybe it's because I'm now unable of being a man onto the wife. So yeah, it might be a little bit tricky to gather that information. Thank you.
Thank you, Mr. Dlamini. Anyone else, team? Yes, my comment has something to share with you, Mpumi, Nduli.
Thank you, Tim. Thank you, Nduli, for the presentation, for the case presentation. I think I have some things I need to clarify in my mind. I'm thinking about the man at 50, and I'm thinking about the wife, the 5 children, and my question is, I'm not sure if you have reached this stage. Are they at home or they are in a rented place? Because that also on its own has a number of effects on the progress that you're going to make as you are caring for this patient. I just want to think, if they are in a rented place, He might want the wife to run the mobile business, the mobile money business. At the same time, this would demand the wife to be out of the house more often than expected, yet he needs the care. And then where are their extended family members in this case? Because the children are really too young to think of 5 and 50 years old, a woman working at the factories now who has been told to stop working. I think there's a lot of data we need as we support this patient. Are they in a rental place or they're at home? Away from Manzini, all those issues need to quickly cross our mind. Thank you.
Thank you, Maggie. I don't know, Mpulu, do you have any feedback for Simpiwe and Maggie?
Nothing much, Mr. Mahlangu. Just to say thank you for their inputs and their advices.
Okay, thank you. I don't know if anyone is here.
We are trying.
Yes, continue.
But we are trying to gather as much information as we can. Some things we are not we don't know as yet, but we will try to probe more questions to ask more information from the patient. But mostly when he comes for dressing, he doesn't go without talking about his children, that who will take care of his children whenever something may happen to him.
Yeah. Thank you so much. If ever you will need some support or how best you can maneuver around this issue of advanced care planning, we can support. You know my number. I can advise wherever we can. Thank you so much, Ntuli, for this case. You know, the way you have presented us, I even feel like we can even represent it again because it's indeed a great case. Next year, when we come back, Ntuli, please prepare a feedback concerning this man. You know, I'm interested in knowing him further. Actually, to know how far you have went and how was his response when you're discussing these issues with him. Otherwise, I think today's presentation will also assist you to tailor-make your going forward, especially in terms of planning going forward with the wound and the planning going forward with the distress that is going through and the issue of the advanced care planning. Though the advanced care planning, we have just do an intro. I'm hoping once we are done with this module, we will look around and redo it again because we will need it more repeatedly going forward because most of the patients, they want to discuss these issues, just that there's a stigma around it. And for the traditional healer issues, you know, at some point we need to ask him what makes him think to go there. You will find that he thinks the wound can be healed again. But if then you are not sure of is this a cancerous wound, I will suggest that you engage the hotel. I'm not sure if Kombe is still there. In terms of ascertaining the status of the wound, that is it a wound that can heal or it's a wound that we are palliating, so that you may not end up wasting a lot of your supplies, so that you are channeling it to palliative type of wound, which we will cover it before we finish the sessions around before May. We will cover that one so that you may know that now we are palliating. So he can know that, okay, if then we are palliating, going to the traditional people knowingly that this is a non-healing wound. I think that one is very interesting. Together with Batantuli, we are saying this is a very interesting case, but we are hoping you are going to continue with this great job you are doing as a team. And we hope you will continue with that one. Continue and look forward for the mother. And so for me, what I've get today is continue managing this wound. I will advise, check with the doctor who can verify if it's really a cancerous wound, and then so that we know the treatment that we are gonna need. So we can even advise him in terms of the traditional doctor, not stopping him, but giving him the information and he can decide and know. But even if you go for traditional healer and then he vanishes from your eyes, continually tell him you will be available to support him at any point in time. And then another issue that I want to share with you is that if possible, we are not saying we can do everything, but I know hospice together with RFM, we can do better for this patient. So, see, now we have a team that go out, even if it requires either your doctors or your psychologists or whoever who may need to go with our team to the field. I think if you can link yourselves with the team from hospice, can also provide you, we can come together and go to the patient where possible and then see what we can do. So I think you can introduce the issue of home-based care. So if he cannot come to you, then we know what to do. Because looking at this condition, it might be progressive and he will not be able to come to RFM anymore. Then we'll be able to do the smooth transition in between. So I will suggest that in your discussions with him with the advanced care plan, please also introduce the home care issue, which will include hospice. If then he is able to do that, collaboration together, us and you, we have the car to go. And when you come together, we can go together as a team and see where you have ended and how we can move together in managing him. So that when he comes to RFM, he finds the same care. And whenever a hospice team has gone alone, is there. And if we've gone together, the hospice and you, RFM, we are able to do that. I hope collaboratively we can do that because we reach them. Maybe on those days, sometimes you will be able even to come with the morphine when we are going with you, and then we are able to manage those pains there. I hope that one can do, but it will be in your discussion with the patient to see if he's comfortable for that, then we will be able to support. May I roughly say the session will end here for today. And may I say to when we come back, please, I'm not saying you are going to present about this case, but maybe your feedback before before we continue with our next session when we come back next year. Due to the holidays, colleagues, we felt like that. Let's just do the introduction today. And then thank you so much to give such a case to go think about this symptom management with many different issues. So our next session will be on 10 January 2024. So where we are going to look around closer to constipation management in patients with serious illnesses. But may I request that we will start with this case, get your reviews on how far you have gone and how best we can support you to continue with this case to ensure it reach the end. And we pray that God give us this man comfortable even when we come back, he's still alive. But again, we will look at constipation. Please don't miss this one because we have seen more patients developing piles, some going for colostomy. We have such patients that now are on colostomy bags because of this problem. So we'll be addressing it when we come back next year, January on the 10th. Thank you so much, colleagues. Thank you so much, Sister Mbata, to see you again. I hope we'll have you even next year. We have our feedback link. You can click it before you exit this session to share with us how was this session, how best we can make it effective. Thank you so much, RFM, for a great case. May God bless you and bless everyone. Thank you so much, Simpiwe. I hope next year you will come with more stuff from Georgetown so that we make a difference wherever we are. Thank you. Bye-bye, colleagues.
Thank you.
Bye.
Nice session. Bye.
Thank you. Bye.
Bye-bye.